Welcome to a special edition of Blood and Cancer, the official podcast of MDedge Hematology-Oncology. I'm the voice of MDedge Podcasts, Nick Andrews. In this special edition, I bring you an interview from our sister show, the Postcall podcast. Postcall is all about conversation and understanding, scholarship, and lifestyle for physicians and healthcare professionals. It's hosted by myself and Dr. Emi Okamoto. If you're interested in Postcall, there will be a link available in the show notes. The guest in episode 31 was Blood and Cancer's own Dr. Ilana Yurkiewicz. In the interview, you'll get a chance to meet Dr. Yurkewicz, understand the passions, perspective, and a bit of the personality behind clinical correlation segment of Blood and Cancer. So we're going to jump into the interview intro between Dr. Emi Okamoto and myself, introducing the interview with Dr. Yurkewicz. Thank you so much for listening to Blood and Cancer, and remember to check in every Thursday for clinical pearls and human perspective in hematology-oncology care with Blood and Cancer, the official podcast of MDedge Hematology-Oncology. Okay, from episode 31 of Postcall, myself and Dr. Emi Okamoto. The interview this week is with Dr. Ilana Yurkiewicz. She is a segment host and producer for Blood and Cancer, which is our hematology-oncology podcast. And yes, this is a bit of an advertisement, but it's also interesting because she's kind of fascinating. Mm-hmm. She has been writing a column for a number of years, and we brought her on to write the column, and we thought, would you like to do the podcast? I talked to her. She wrote science fiction. We had a common love for Ted Chiang, who's a great science fiction writer. He wrote the short story. It inspired my favorite movie, which is Arrival. And once I watched Arrival, I had to read about him, and so we talk about that. But she does this thing called clinical correlation in Blood and Cancer, which is a way to take the clinical advice and kind of pick out the anecdotes of the struggles that patients are having. Things like financial toxicity, things like recently she had a really poignant one where it was called Lie to Me, where the patient needed her to tell him it's going to be okay, even though, like, I know it's not. I just need you to tell me that it is, please.
Yeah, and she's kind of in this position as an oncologist that a lot of us work on this every day, and not to the degree that she does, but it's still so useful. I read a few of her pieces. The Doctor, Will You Lie to Me is what it's called, as well as other things. Just, should we disclose preliminary results, gatekeeper, kind of dealing with the same things that every clinician and every physician deals with on a day-to-day basis, and just writing that out so that we can share that experience and we can have an idea of how to navigate those situations, which she goes to say for a lot of them, there's no perfect way, there's no right answer, but taking the time to kind of dissect and say, okay, what are we feeling, and reflect on that. Right,
where I think that with the Doctor, Will You Lie to Me, and then I think there was one about disclosing the results of the test, which is really interesting. And she says in her piece that this feels incorrect to me. And even though the mother, or I think it was wife and daughter, convinced the patient, this man, that, like, you don't want to know. And he said, I do want to know. And then they said, you really don't. And then he looked at Ilana and said, I don't want to know. And she said, this is not, this feels wrong. He needs to know.
Yes.
But he decided he didn't want to know. And what a weird thing, because it's just, oncology is fascinating to me in that it goes from scientific to very emotional, like when you walk through the door, which is really fascinating. She does a great job. And you can listen to her every week on Blood and Cancer. And there will be a clip that we're going to insert into the podcast at the end. But it's time now to go to our interview. Dr. Ilana Yurkiewicz. Emi, thanks for hanging out.
Thank you.
I'm here with Ilana Yurkiewicz, and you have been doing, Ilana, the clinical correlation segment of our Blood and Cancer podcast for a while, and you also write a column for MDedge.com/hematology-oncology. And so I'm excited to get to talk to you finally. I've been producing your show for quite a while, so I guess I just want to start by getting the basic information. Where'd you go to undergrad? Where'd you go to med school? Where'd you go to residency? Where'd you do your residency? And why did you choose to become a doctor, and why did you choose the specialty that you did?
Yeah. So, well, first of all, thank you so much for having me on your podcast. I'm really excited to talk to you. So I went to undergrad at Yale, and then I took a year off between undergrad and med school, did some research and did some work in bioethics, and then went to med school at Harvard and then did my residency at Stanford, and then liked it so much I decided to stay on for a fellowship in hematology and oncology, where I'm now at the end of my first year. And I decided to become a doctor initially for kind of some of the classic reasons that people will bring up. I thought it was a really good combination of being able to help people directly while also using a background in science and applying a background in science. And I was always the kind of person that both liked the sciences and the humanities, and I thought medicine would be a really ideal way actually to combine them and see direct impacts on real people. And it lived up to my expectations for sure. And when I came into residency, I was actually undecided I didn't know what specialty I was going to pursue or whether I'd pursue a specialty. So I did my residency in internal medicine. And for a long time, actually, I thought I was going to be a primary care doctor. And I still absolutely do love primary care. But then kind of halfway through my residency, I rotated through inpatient oncology and hematology, and just absolutely loved it and felt this new draw to the specialty of hem-onc, which I then did a fellowship in. And I think the reason why I felt so drawn to it, I think there were a couple things. So I knew that I liked being a primary provider for my patients and taking care of people who are both medically complex, but also who are dealing with kind of high stakes emotional and psychologic issues that were related to their underlying illness. And when I rotated through the cancer ward, I just felt like this was work that really, really, really mattered. I was able to develop longitudinal relationships with patients. I felt like I was helping people through some of the toughest and most vulnerable times of their lives. And it was just incredibly rewarding work. And so I decided to do this fellowship, and that's where I am right now.
Yeah, so it seems like it's working out for you pretty well. I started my medical media career in oncology as a writer, and I found the specialty very fascinating because of all of the fissures that go along with being diagnosed with cancer as a patient. You get like you mentioned, the psychological aspect. I got particularly interested in financial toxicity and things like that. It's so all encompassing that I imagine that there's got to be a lot of energy there, but there's also like probably emotions that you're working your way through, or these really complex things that how would one know that was going to, make you feel that way? And it looks like you have an outlet and some opinions that are on our column. Your column is called Hard Questions. And I'm going to read some of the headlines here. They kind of emphasize what I'm saying, where there are some gray areas in the clinic with patients. This one is called "Should Doctors Disclose Primary Results?" I also was really into this headline is really interesting. "Doctor, will you please lie to me?" Mm-hmm. And so I wanted to know how writing and telling those kind of stories it helps you, I guess, kind of express yourself, but then also how's the feedback gone, and what's it like to kind of put these things on pen to paper, as it were?
Yeah, definitely. So I think, first of all, I completely agree with what you were saying about, practicing oncology and it being all encompassing. There are a lot of emotions to work through, both dealing with your patients and the family dynamics that go along with that, and then as well as working through your own emotions. And there's a lot to process in the field, which is one of the things that I love so much about it. And so when I started out my fellowship, I created this column that you mentioned called Hard Questions. And I tried to think of what would really encompass what I wanted to write and grapple with during my fellowship. And I thought Hard Questions was broad enough that I could really just delve into kind of whatever situation with patients that I found that I needed to work through, that I could get through it with writing. And so it's a monthly column, and it comes out the first or the second of each month. And like you mentioned, so each column explores a particular, I would say it's a human side of hem-onc care, and a particular issue within that human side of hem-onc care, and often an ethical situation that goes along with providing that care. So you mentioned one of the pieces I wrote that I really thought about for a while, "Doctor, will you please lie to me?" It was about a patient who presented to me and had unfortunately very aggressive metastatic cancer, and asked me to basically tell him that the cancer could be cured even without any treatment. And he kept pushing me to say something that felt like it would be overly reassuring and not accurate. And at the time, I felt like I was in a really tough spot. Of course, you don't want to lie to a patient. At the same time, you don't want to remove hope. And so I explored that encounter in the column. And I think by writing about it, it forces you to make sense of your own experiences and to come away with a lesson from those experiences. And so I've tried to do that with each one of my columns. Usually it's something that I'm trying to work through myself. And I find that by writing it down, I can often reach a conclusion that I might not otherwise reach if I didn't really force myself to put it into words. So writing can be therapeutic for me that way. And my hope is with the column, of course, it's not just for me. I write in order to be read, and that other providers and people who aren't in medicine will also read this work, and I hope it resonates with a broad audience.
Yeah, and I think because it's so, I don't want to say anecdotal, but it's very much like you're like looking through your eyes and what you're experiencing in the clinic. It's very interesting to me because I don't want to say only a fellow, but you're only a fellow in that you're at the beginning of the timeline of your career and you're having these kind of observations and thoughts as a writer. So what is the next, as a writer and as a clinician, what do the next 5 to 10 years look like? Are we smelling a book or a book tour or anything like that? Or what would you just plan on keep throwing these out there and seeing what happens?
Yeah. So, maybe first I'll answer, just writing has always been a part of my career, even as far back actually as my undergraduate days. I first got interested in science and medical writing back when I was an undergrad. I then did a fellowship after college where I explored science journalism. I blogged throughout medical school, and then I've also done long form science and health reporting for different outlets. So I've always known that was going to be a part of my career. And I see it in parallel to my clinical career. So I think I do know that writing is going to be, something that I will continue to pursue. It's not a question of if, it's just a question of what form it takes. So while the specifics aren't exactly worked out, I do look forward to new opportunities.
Speaking of that, that's an excellent segue, and I suspect that as a newly minted podcast, you may have done that on purpose, but you have a new form of writing where you're writing scripts and you're recording them as a segment to a podcast that we launched on this network called Blood and Cancer, which is a revamp of a JSCO interview podcast. It features Dr. David Henry, who's a superstar, and he just does interviews that are relevant to clinical oncologists, just pearl heavy, how to do interpret statistics and what to tell patients. And you are the cherry on top of the show at the end with the human side of oncology. It's called hematology-oncology. It's called clinical correlation, which is sort of essentially an audio version of the blog. Have you, or your column, have you enjoyed being on the podcast, and what have the challenges been for you? And also, do you find any differences between writing scripts, turning your columns into scripts, and writing for spoken word?
Yeah, so this was my first time doing podcasting, and it's been such a wonderful experience so far. Like you said, I created this segment, Clinical Correlation, which is similar in content to what my written column is about, but it's a short segment at the end of Blood and Cancer. It's about 2.5 to 3.5 minutes that I produce every week. I found there's some overlap because I do write the script down before I record it. So, in a sense, it is just writing and then I'm reading my writing. But at the same time, I've noticed that stuff that I think can land when you're writing might not land the same way when you're speaking, and vice versa. So when I write the scripts, I read them out loud before I record them too. And sometimes I kind of write and talk at the same time, if that makes sense, just to see how it actually sounds when I write a sentence. And so, it's just a little bit different way of writing and getting information across. And then, at the same time, it's kind of nice to have your voice as just another agent to, express content or emotion. The ups and downs of your voice can actually be expressive too. And I've just found working on it just a wonderful experience and a good learning experience for me.
Yeah, so the podcast is doing really well, and we're very happy, obviously, to work with you and work with Dr. Henry. And I'm obviously is my job description podcast host, but I'm a big fan of audio specifically for healthcare professionals, doctors and nurses, etc., because there's not a lot of time to do reading and writing for fun. You need to keep up with literature, and you need to, but you're expressing yourself, and you can turn it into other things. However, audio is the only format that I know of where true multitasking can be kind of relevant, where you can get something out of it without giving it 100% of your attention. So I'm obviously a big fan of it, but so you do this 2-minute segment. What do you think about conveying medical information through audio, and what do you think about your future in podcasting? Is it something that you want to continue to do and maybe have a bigger role?
Yeah, like you were saying, I mean, I think it's just a great opportunity to convey medical information. So when I drive to work, for example, I'm always listening to podcasts, and, I'm multitasking. I'm driving at the same time. I'm often doing other things, and I often take walks and I listen to podcasts. So I consume a lot of information that way myself, medical and otherwise. And so I was really excited to get the opportunity to be a part of creating that information. I will keep doing it as long as, I enjoy doing it. It's always hard to kind of predict exactly what the future is going to look like. But I've really enjoyed doing it so far. And I like the challenge of coming up with information each week, too. The column that I write is only once a month, but the podcast is once a week. So there's also a lot more content that I need to produce. And I kind of like that pressure.
Yeah, it makes you feel alive, right? Like, I got to get it out. It's 2 days left.
Yeah, exactly. And so every week, at the end of the week, I'm starting to think about, well, what's this podcast going to focus on? And it forces me to condense some of the stuff I've done that week into a good learning point.
I want to switch gears a little bit and get to know you a little bit more personally. You are currently located in the Silicon Valley. A lot of hot things going on, Golden State Warriors and Google and all that stuff. It's a good place to be right now. And tell us a little bit more about yourself, siblings and hobbies, and kind of how you deal with stress, or what you would do on vacation, or if you were alone by yourself, what music would you be listening to, that kind of thing.
So I have a sibling who's also in medicine, and who also writes about medicine, actually. Her name is Shara. And we actually went to undergrad and medical school together, and then did residency in the same place too, all not intentional. But she is my closest friend, and I'm very lucky to be able to live so close to her over all this time, so we could spend time together. And she's currently a chief resident in PM&R, that's physical medicine and rehab at Stanford. And then she's going to do a palliative care fellowship starting this summer at UCLA. And she's also written and blogged about medicine before. And so it's really nice to have a sounding board, and I think we can bounce ideas off each other. And she's someone who thinks close enough to the way I think that we always have good conversations, but at the same time she can offer different perspectives. And that's just been extremely valuable to me throughout not just my medical training, of course, but my life. So I'm pretty aggressively protective of my free time, I think, with just such a busy career in medicine, that it's a good question to ask people, I think, on your show, that because we're so busy all the time. So making time for things you enjoy doing is so important, so that we don't burn out and we're able to continue doing the stuff we love. So for me, being outdoors is just a big part of stuff, the way I kind of rejuvenate after a long day or a long week. And I'm lucky to live in a place like California where I can do that most days of the year. So I like going on hikes, and I like going on walks. Walking is also a place where I end up sometimes coming up with ideas for the stuff that I'm writing. It's a creative space for me. And I do spend a lot of time reading. I think you mentioned earlier, we spend so much of our time reading journal articles in medicine, but I've actually been pretty aggressive also about making sure that I'm reading non-medical stuff on a regular basis.
Is that for education or for pleasure?
It's for pleasure. Yeah.
So are you into fiction or nonfiction?
Both. I'd say fiction is more of an escape for me. It's just an opportunity to kind of immerse yourself in a different world. And I think it helps me with my day job for sure, because I'm able to decompress and So I still read on a very regular basis despite my busy clinical schedule, and I don't see that as extra time. I see that as it helps me, with my day job.
What have you read recently? Give us your most recent fiction and most recent nonfiction for fun.
Yeah, so I'm almost done now with this book of short stories by Ted Chiang. He's a science fiction writer. He's
All right. Ted Chiang is my boy. Arrival is my favorite movie.
So I've actually never seen the movie. I think I just love this story so much. I was afraid, that the movie would ruin it for me somehow. So he has another book out. I don't know if you knew that. Another book of short stories that just came out.
No, I didn't know that.
And so some of them have previously been published online and some are new. So, of course, the ones that have previously been published, I had already read. But there is new content in there. And so I would highly, if you love Ted Chiang, you have to buy this book. Story of Your Life it's just one of the classics for me. It's one of my favorite sci-fi collections of all time. And fun stories, actually, before I was interested in writing about medicine for public audiences, I actually did science fiction writing myself.
Really?
Yeah, and I discovered Ted Chiang because I submitted a story to a professor in college. And he said, your stories this is such a high compliment. Don't believe this or anything. But he said, your story reminds me of this guy I know named Ted Chiang. And that's how I actually first discovered him. And I picked up his stuff and I was like, whoa, this is just the much better version of what I'm doing. But
yeah, you're like, oh, this thing that I was trying to do, he did that and he did it perfectly. So I guess I'll quit.
Yeah, but I liked what he did, and I think what I was doing as well was actually using, real science concepts as the foundation for the story, and where the idea of the story is what matters most. And so, his stories really make you think, and it feels like they're based on real science and real psychology, and that's what I love about them. Yeah.
I am fascinated that you were writing fiction, and any plans to continue that, or maybe like down the road one day?
Yeah, like I said, it's hard. I don't plan all this stuff in advance,
Sure.
Believe it or not. I kind of just do things that I like, and then if I see a good opportunity, I'll jump on it. And so right now, I've really enjoyed doing the medical journalism, and that's where I think I intend my future career to go. But if there's some space or some opportunity for me to continue doing fiction writing on the side, by all means, that might be something that I want to pursue too.
Yeah, you never know. That makes total sense. Okay, so we're recording this around the Memorial Day holiday, and that is one of the craziest times for people in the medical profession who are between the ages of 24 and 30 or so, because they're starting their residency or they're starting their internship. So I want to throw it back to you. When you started your residency and internship, what was some of the best advice you got and some of the worst advice you got? Don't have to name names, obviously.
That's a good question. So I would say some of the best advice I got was from one of my mentors who was trying to explain to me the difference between tasks that were urgent and tasks that were important. And I think this comes up in medicine all the time, where you're basically carrying a pager and you're on call, a lot of the time, and you're constantly being asked to do things. And initially it can be difficult to tease out just what you need to do because someone's asking you to do it right away and what's actually important. And sometimes the important tasks are the ones that you can't really check a box for it. For example, time to think deeply about your patient, or time to look up information. And I think for me, being able to make that distinction between urgent and important tasks was really helpful in prioritizing how I went about, prioritizing my own time in taking care of patients and doing outside tasks as well. So I thought that was really good advice. I'll give a second one just because we're on a podcast called Postcall.
That's right, we're Postcall. Yeah,
I'm actually Postcall today, believe it or not.
Awesome. Pour yourself a glass of wine. Let's do it.
And so the other piece of advice that I got was great, is don't make any major life decisions post-call, which I just want to emphasize to everyone who's listening to this how true that is. And I'll tell you, I was once in a situation where I almost made a big mistake post-call, where I just had been working on this project for months and I was really excited about it. And I think I was just so overwhelmed and tired from my call day. I called up the person I was working on. I'm like, hey, I'm not going to do this anymore. I'm backing out, which was a terrible decision. And I basically just had to call back the next day and be like, hey, can you just ignore kind of everything I said? I was post-call and I wasn't thinking clearly. So really, just don't make any major life decisions post-call. You're not at your best. You're not thinking clearly.
It's worse than you hear people like drunk texting and stuff. Like I have friends in residency and they're like, it hurts your stomach. It messes up your sense of time. It's just go home and watch some Netflix and go to sleep.
Go to sleep. Yeah, that's my advice. Go to sleep.
Put the phone
and
down.
then, yeah, exactly. And then, so worst advice. I don't know what the worst is, but I'll say some advice that I don't like, that I think actually gets perpetuated a lot in medicine and for trainees. In terms of choosing a specialty, people will say things like choose your tribe to you. Which means find a group of people that you feel like you relate to and pick a specialty in medicine that way, pick your future in medicine that way. And I actually really don't like that advice, and I think it's bad advice. And I think it actually kind of perpetuates certain stereotypes and biases of what kinds of people can do what kinds of specialties. That's bad for medicine and it's bad for the individual. So when I was deciding my specialty, someone said to me something like, "You're too nice to do hemonc," whatever that means. And I think if you feel like you think, and for the record, I think people in hemonc are extremely nice, so I don't even know what that means. But I think if you think differently from people in a specialty, but you like that medicine, all the more reason why that specialty might actually need you in your way of thinking. So I would say don't choose your tribe. Don't just choose people that you feel like you get along with. Choose the content that you're most interested in, where you feel like you can make the most value add.
I think that's really interesting that you say that, because I don't want to stereotype or get into the chicken or the egg, but there are specialties in medicine where I can predict the population of people that are in it. And I don't know how comfortable that makes me feel. I don't know if it's because the specialty attracts people of a specific gender or personality type, or if it's because there's sort of like a mantra that's shoving people into that. And I think that's a really good point that you make, because the more diversity of ways of thinking that you have, you're going to come to new conclusions, and people are going to pitch ideas that no one's ever heard before. That's just basic team building.
Right. And I think it's self-perpetuating why certain specialties end up the certain way, because you get advice in your training of saying you should do this or that because of, really superficial characteristics or personality, quirks that you have. And I'm completely against that. I'm with what you said. Different ways of thinking are better for a specialty. It's better for medicine. So just find the content that you love and just pursue that.
I wanted to know what you think is going to be the future of hemonc care. Where's palliative care come in? What about the quote-unquote healthcare system, financial burden? The new immunotherapy revolution is very exciting. With CRISPR, we're going to learn a lot of new things. What does cancer and hematology look like in the next 10 years? Or what's your best guess?
Yeah, what a big question.
Yeah, right.
No, I love it. So I think there's a couple ways I could answer this. So first I'll say, I think one of the most important things for cancer is early detection and prevention. So actually the bulk of the important stuff that's being done in cancer is not being done by oncologists, it's being done by primary care doctors who are first line of defense. And so there's so many modifiable risk factors that we already know about in terms of preventing cancer, like smoking cessation, increasing physical activity, reducing obesity. And then there's other things like vaccinations. We know that there are certain infections that are tied to increased risk of cancer. But we're not meeting benchmarks in a lot of those areas. For example, we know the HPV vaccine is highly effective at preventing cervical cancer, and rates of vaccination are just not nearly what we want them to be. So there's so much work to be done in prevention and early detection. And we have a lot of great tools. It's just about implementing those tools. And I think it's a big question for patients is being able to access providers on a regular basis. And that's not at all, of course, specific to oncology, but just a problem of our healthcare system is there's just big swaths of people who just don't have access to medical care in the way that they need access to medical care. And that's just a problem for all of healthcare. I think another thing that I'd like to touch on is what you mentioned about, immunotherapy and cellular therapies. I'm really excited. I'm really excited about all of that stuff as a hemonc fellow. So I think previously the way we thought about cancer, and again, I'm going to paint this in really broad strokes and generalizations, but we would think about the cancer cells and how to kill the cancer cells. So cancer is the disease. What's the best way to kill that? So things like chemotherapy, which are medications to kill cancer, things like radiation, which is shooting laser beams to kill cancer, things like surgical oncology, which is cutting cancer out with the scalpel. But I think the paradigm has been shifting more and more towards the role of the host and harnessing the power of the immune system to then be able to turn back on cancer and to help. The cancer has developed kind of these white flags that say, I'm innocent, don't hurt me. And the field has developed towards removing those white flags in a way and making the immune system stronger at attacking cancer. And I feel like a lot of the future of oncology is just in that kind of broad approach. And that's given us things like immunotherapy and then CAR T-cell therapy, which they're not holy grails, they're not cure-alls by any stretch. I think we need a lot of tools in our toolkit to fight, a foe as clever and dangerous as cancer, but they're really strong tools, and I think the field is heading in that direction more and more, and I think that's all been a very positive thing. I will mention as well the palliative care aspect of it because you mentioned that, and I agree that that's really important. And to me, I see palliative care as a philosophy. You don't need to be a palliative care doctor to have a palliative care philosophy and to bring that to your approach to hematology and oncology. And it's just about putting the patient at the center of care and really taking into consideration the holistic picture and things like quality of life. And the more and more we integrate that way of thinking into our hemonc training, the better off we'll all be.
Okay, thanks so much for coming on. I really enjoyed having you. It's been too long. I think that we're gonna have to have you back down the road after we get some more of your columns and get some more blood and cancer episodes. That was a great way to end the show. Thanks for joining me.
Sounds good. Thanks so much for having me.
And that concludes the 31st episode of the Postcall podcast by MDedge. I'd like to thank Dr. Yurkewicz for joining me this week. You can stick around or jump to the very end of the show after the credits for a sample of clinical correlation to get an idea of what Dr. Yurkewicz does for blood and cancer. There's also a link to both her column and blood and cancer in the show notes. Okay, let's get to the credits. Postcall is hosted by myself and Dr. Emi Okamoto. It's produced by MDedge Executive Editor Denise Fulton, along with MDedge Editor-in-Chief Mary Jo Dales, Multimedia Editor Terry Rudd, and Executive Editor Kathy Skarback. Kyla Clark handles the social media. I do the writing, the editing, the producing, and the engineering for Postcall. Thanks for taking the white coat off with us again this week.
I'm Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. Today, I'd like to share an everyday story about the financial realities of having cancer. One day in clinic, I met a retired librarian, let's call her Andrea, in her mid-70s. Andrea had chronic lymphocytic leukemia, or CLL. She initially presented after routine blood work showed an elevated white blood cell count. She felt well. No fevers, no fatigue, or night sweats, or weight loss, and she didn't have any enlarged lymph nodes. All in all, she was diagnosed with stage 0 disease, meaning we could watch and wait for now. About a year later, however, she started to feel fatigued. She wasn't anemic and still didn't have enlarged nodes. The source of her fatigue was unclear. She admitted she was undergoing a move that was taking a lot of time and effort. Was her fatigue related to progression of CLL? Or was it just simple, unrelated, everyday fatigue? Making that kind of distinction is something we are tasked with doing in medicine all the time. It's tough, it's often a judgment call, but it's important because it has implications for treatment. The implications for Andrea would be whether she should begin treatment or not. We discussed what that would look like, a daily pill called ibrutinib. She nodded and agreed, and then casually asked what it would cost. It's a pricey medication, even with good insurance, And with her insurance plan, it would come out to $900 out of pocket every month. When we said this figure, her mouth literally dropped open. So she asked, "Doc, do I really need this pill? Or can we continue to watch and wait?" Now is the time in the story where Andrea has a choice. It's a universal story, press play over and over in hospitals and clinics throughout the country. Do you do what's medically best, no matter what? Reach out to her ex-husband for money, spend her retirement time taking on a new part-time job, sell some household items, or take the chance and defer treatment for now, because watch and wait is an option, and it's the free option. The question of whether to initiate treatment would have been difficult, even without cost implications. The cost factor made Andrea understandably want a certain answer. Medicine, unfortunately, lacks certainty. That does not square with financial realities. In the end, Andrea chose to watch and wait. A few months later, her fatigue got worse, and she started to lose weight. At this point, things were more certain. Now, she did need treatment, and she'd used those few months to figure out a way to pay for it. I think Andrea made the right choice, but I wish it wasn't a choice she had to make in the first place. Thanks for listening, and I hope you'll tune in next week for Clinical Correlation.